they're aware that they've got greatly elevated B2 microglobulin, and they're aware that sort of even mild renal impairment may elevate that. As the expert on this, how concerned are you when you see a lupus patient with persisting greatly elevated B2 microglobulin, and how much of an impact do you feel it has on a patient's well-being?
So, B2 microglobulin can be a marker for certain hematological kind of issues. How concerned am I? Well, I'm not overly concerned, and if you've got renal impairment as well, there'll be a lot of molecules which won't be easily filtered through the kidneys. So I'm not overly concerned about it, so long as the clinical features, again, don't point to anything untoward. And when you've got markers like this, they don't always mean anything. So again, when you've got somebody like that has raised markers, the golden rule applies. You look at the patient, ask them questions. Have they had any particular issues with weight loss, untoward issues which are unexpected? What's the clinical examination like? And what do the tests show? And if that's the only abnormal test and they're fine, a watch and wait strategy is absolutely fine. So I'm not overly concerned. And tests, the more I look at tests, the more actually they only really have meaning in the clinical context. So your clinical features are going to be really, really important.
Thank you very much. I hope that helped with your question. This next one, I think, I don't know who it's most appropriate for, so I will let someone put their hand up on the panel to answer it. First of all, do studies and trials differentiate between male and female bodies? And are there any studies looking at the impact of the menstrual cycle on lupus symptoms? Anyone want to volunteer to take it?
Excellent, that's a good sign.
So in terms of men and women, they tend to be lumped together. So if you look at the results of clinical trials, they will give demographics of the patients who are included, and they'll give you the proportions of men and women, but the analyses are almost always done as a single group, which we recognise is a problem, because the handling of drugs by men and women is very different, and the response in different sexes can be very different. So that is something that is likely to change in the future. We're also very aware of the need to ensure the inclusion of people of different racial origins in clinical trials as well. So until quite recently, they tended to be male and white, and improving the recruitment in different groups so that it's representative of the population is very important.
And in terms of the question, I think it was about menstrual cycle and lupus activity. So it's something I actually considered a few years ago, where we were looking at patients who are iron deficient. We know that the leading cause of iron deficiency in the Western world is through heavy periods. And yet we sat in a clinic of which 90% of the patients were women, of which the predominant amount were young women. And I realised that no one had done any research into that area. So we actually found did a very small study showing that menstrual cycle does seem to be slightly dysregulated in patients with lupus, and it really struck me that how kind of under-researched that area is, given that you've got an illness that predominantly affects young women. So it's a very good question. I don't think anyone's actually done any proper good studies into the effects, but from anecdotal evidence, lots of people will often speak to us and say they know that they are going to flare at particular times, and they have reported sensitivity to hormones. Similarly, we do know that there are concerns about certain artificial hormone changes. So, for example, contraceptive pills containing estrogen have been, we're advised not to use those in many cases of lupus. But the actual mechanisms of that are unclear. I do know some people who are doing the science behind it, and hopefully there'll be some interesting research coming out soon. And it's much along the comments of men, women, those hormonal changes in the development of lupus is something that's currently being looked at very closely, and we'll hopefully have a better understanding in the next few years.
Lovely, thank you. I hope that was helpful. So the next question is for Dr. Wincup, who said that during your talk, you would email sort of other health professionals to provide a more holistic approach. So this is from the patient perspective. So how can patients sort of help themselves from being pushed from one ologist to another?
It's a loaded question. So yeah, I mean, it's slightly tricky. I can talk about my practice, and the way that I practice is we have a helpline for our patients, and the nurses look at the helpline and the emails, and I give it to everyone. It's on everyone's clinic letter, and then if the patient has a problem, they send it through to the nurses. They see my name next to the patient, and then they send it through to me, and I try and deal with it. So, I can try and bias that answer by saying I think that's a good way of doing it, because that's the way I do it. But the way that I think that it probably works for me is having a relatively open door for concerns. And if I get a message from a patient saying I've got this really terrible headache and I don't think it's due to their lupus, then I can try and find the right person to look after that. I think it comes back to kind of one of the points that I mentioned earlier, where if we don't know the symptom and we're not looking for it, then we can't do much about it. So if you do feel you're being pushed around between different ologists, it's worth speaking to at least one of those people about your feelings relating to that. And again, without being biased, but I think as a rheumatologist, we're kind of seen as doctors that look after joints. So why we're looking after all of lupus that affects the skin and the lungs and the heart. But I think it is because we are probably the ones that coordinate quite well with all the other specialties and are connected with others. So bringing that up to your rheumatologist may give you the opportunity to allow them to advocate for you.
Thank you very much. The next question I think is probably for Sian, but Arvind or Chris may want to weigh in. So the first part is, can you have normal bloods but have kidney disease? I.e., is the urine test critical to the discovery of lupus nephritis? And at what time or class are lupus patients referred to nephrology?
Thanks. So, unfortunately, the blood test doesn't give you the whole answer. The urine test is very important. So the substance we measure for your kidney function is creatinine. And your kidney is very good at adapting to a loss of those tiny blood vessels. So your creatinine will actually stay normal whilst there's damage ongoing, because the remaining kidney is coping with the filtration. So by the time the creatinine actually changes, things can be quite advanced. And I don't think that's terribly well appreciated sometimes. So the urine test is absolutely critical. And you can have a significant amount of protein in the urine, which would cause us to act, despite the kidney function being quite well preserved. So that is very important. Oh yes, there's a bit about classes.
Yeah, when would someone be referred to nephrology?
Oh right, so if you've been seen by a rheumatologist and they're concerned about the urine and blood tests and think you might need a biopsy, then you'll come to us then. So and it may be that we say yes, it does look as though there's some involvement, but we can control it with some simple measures, and protein settles down and you don't need a biopsy because the treatment is dictated by that of lupus. But if that's not the case, then we would do a biopsy, which, as I say, may indicate escalation of treatment or and prognosis is good for that.
I have my tuppence worth in, which is that it's important for you all to have sort of specialist care as part of a multidisciplinary team. And the question is, when would a rheumatologist refer as early as possible? There's very good evidence that even tiny little flares of lupus, which may not require a biopsy in the kidneys, eventually will lead to permanent damage. And if you ignore those enough times, you will get chronic kidney disease and end up with dialysis almost certainly if those are ignored. So it's really critical that rheumatologists refer you early. The kidney doctor can make the decision about whether a biopsy is warranted, because there are inevitably risks with that, or whether it can wait, but treatment is not an option. It has to be treated. It can't be ignored.
and just kind of adding on to kind of the previous question that was asked of me, so we have very close relationships with our nephrologists. We have a weekly meeting with them to talk about all our patients who we have concerns about, and we can discuss any concerns in bi-directional manner. So the renal doctors speak to us, we speak to them, we raise cases, and again, that's another way of stopping you being passed around between different nephrologists.
Thank you very much. The next question I'm going to ask Arvind. It's on a topic that we haven't really discussed today, which is antiphospholipid syndrome. So someone's asked, if one identical twin has APS, does it follow that the other identical twin is highly likely to have APS too?
Well, that's a difficult question to answer, but in general, it's not mandatory. It depends what identical means. If they're genetically identical, then the risk is definitely going to be higher. And it's the same with lupus. If you've got a genetically identical twin, your risk of lupus may be higher in a genetically identical twin. So the same is likely to go for APS. The genetics aren't as well established as with lupus. And I think what you have to do is make sure you check all the antibodies. You've looked at all the risk factors for either twin and treat it appropriately. And if one has an APS and the second one doesn't have formal diagnosis of APS but has the antibodies, you may be tempted to give them baby aspirin, for example, longer term to prevent thrombosis. So I don't think there's an awful lot of data on twin studies with APS. But certainly with lupus, there's a higher risk, and the same would inevitably, I think, follow really with APS. So protect if the second twin hasn't had APS formally. They'll be at higher risk if they've certainly got the antibodies for sure, and then using a baby aspirin, whereas with full-blown APS, unless it's pregnancy-induced, warfarin is the mainstay of management. So aspirin for prevention, warfarin for treatment. The only exception to that really is obstetric APS or pregnancy-associated antiphospholipid syndrome, where aspirin and heparin are given throughout the pregnancy and for a few weeks after the pregnancy in the critical period.
Thank you. The next question, I'm going to go to Chris first, but the others may want to weigh in. What is your best guess as to the cause of lupus fatigue in general?
There's murmurings within the audience, so well, my best guess would be that it's a problem relating to iron metabolism, but I would say that because my PhD was on fatigue and iron metabolism, so if that's not my best guess, I've done a dreadful job at my PhD. What I would say is it's probably a combination of things, and we have these arguments quite a lot. So disease activity, number one. If the lupus is active and you've got loads of chemicals floating around, very similar to what you get if you're, for example, fighting an infection like flu, that's going to make you feel fatigued. So as an approach, make sure that the lupus is settled. Then we have a group of people who have very well-controlled lupus, as far as we can tell, with relatively normal blood tests and no other symptoms, who have high levels of fatigue. So having shut down the disease, we can't blame it on the disease being active. And in those patients, I like to look for other things. So is there a problem with the thyroid? Is there a problem with other vitamins, vitamin D deficiency, things like that? So you can screen for these things fairly easily. Sleep, that's an important thing to consider. And I say that having been up till 1 o'clock writing the talk that I just gave this morning, that we don't appreciate fatigue and sleep. And we know that patients with lupus have significantly disrupted sleep for a number of reasons in large studies. Furthermore, pain is a key contributor that will disrupt sleep. So you look for all of those things, and you may see fibromyalgia, which is another thing associated with fatigue, which is seen at much higher levels in patients with lupus. And I'd say that probably accounts for fatigue in maybe half of lupus patients, where you can blame it on those things. And then there's another half where we just don't know. And then if you're asking me the question that I'm trying to avoid giving you an answer to, that I should be able to answer, which is what's the best guess? Well, what's causing the problem there? Well, my hope would be, and I'm very biased on this, is that maybe there is an autoimmune or inflammatory cause for that fatigue that we can't yet detect. So it doesn't make sense that we just blame this on fibromyalgia when we know perhaps only 10% of patients with lupus have fibromyalgia and 90% of patients with lupus are fatigued. So is there something immunologically going on, and much like my talk, affecting the central nervous system that could be contributing to it? And that would be my hope. And the reason I say it would be my hope is because if we do find something like that, that may be more amenable to treatment than just kind of shrugging our shoulders and going, one of those things.
Just to add to Chris's excellent summary, I think remember that fatigue exists in most lupus patients, but it doesn't mean to say nothing can be done about it just because we can't explain it. It's a long way to go before we get full explanations for many things, but it doesn't mean to say nothing can be done. And there's very good evidence that exercise will help, psychological interventions. There was a study on using Wii Fits, and doing gentle aerobic exercise will help you reduce fatigue. So it is a very multi-dimensional symptom. I find hydroxychloroquine is very good for fatigue, and I don't mean just for lupus. And remember, fatigue is present in a lot of people who don't have lupus. So there are clearly non-immunological mechanisms around fatigue, and I find hydroxychloroquine actually helps significantly with a lot of people who don't even have lupus. So there are elements of care that I think are appropriate for patients with fatigue, which you should be having really.
Thank you very much. And the next question, I'm going to give to Sian because she is a consultant in Wales. But I'll give you the question as it's phrased at the moment, and that's: is there anything in the pipeline for a lupus specialist in Wales? Now, I don't know if anyone who's here is this specifically about rheumatology as a specialist of lupus, because obviously there are lupus specialists within several different specialisms. But I just wondered, maybe you were able to share anything about the specialist care of lupus in Wales?
So I can comment a little bit on how services are organised at the moment. So we were talking earlier about the lupus MDT teams that they have in London, where they have very large clinics with a lot of patients. In Wales, because we're mostly a white population, we have fewer patients with lupus. So our MDT discussions, we don't have enough people to talk about every week. So we tend to do it when we need to. And so I speak to my rheumatology colleagues in Cardiff and at Royal Morgan quite closely. I have colleagues who go to the Gwent who will be speaking to rheumatologists there, and then Swansea will be coordinating care for South West Wales, and similarly the units in North Wales. So we don't have a single point of contact, but we do have fairly informal, close working. So I speak to rheumatologists probably every two or 3 weeks about one of my patients. And then when we do speak to David De Cruz in London about complex patients. So I talked about the sort of the treatments we go through. It's not uncommon for people to not be able to tolerate some of those treatments, or to have quite significant adverse effects from them. So we do use different treatments in different combinations for different patients, and we would certainly have an MDT discussion about that and involve other experts if needed. So we don't have a centre of excellence in Wales, but we do work with them in England, and they're always very helpful when we do pick up the phone and call them.
So the next question, I'll ask Arvin first, but for the others, they can pitch in. Is there an increase of getting cancers with autoimmune diseases such as lupus? And then they've said, I think what they might mean is, and also being on autoimmune treatments. So is there any data about that?
Thanks. There is some data, and this is always a controversial area because it was long thought that certain cancers may be more represented in autoimmune conditions. So there's certainly a higher risk of conditions like lymphoma for those of you who have conditions like Sjogren's syndrome. If you've got myositis with specific antibodies, for example, which is inflammatory muscle disease that overlaps, there is a higher risk of cancer with some of those conditions as well. With lupus, it's always been a little bit controversial, but there is some evidence that certain cancers do increase. Things like cervical cancer is increased in patients with lupus, so you should have screening done regularly. And at all times you have to be vigilant with therapy, so skin cancers are increased with drugs like azathioprine. So there are some increases with specific types of cancer with treatment as well. So at all times you just have to be very mindful of the treatment you're giving and the condition. So you need to be self-examining breasts, for example, watching out for things like weight loss, any odd growths, and being told that azathioprine you might have a slightly higher risk of skin cancers as well. So this is all in the background, but obviously needs to be centre stage for some people as well, particularly those with conditions like Sjogren's.
Okay, so I think we've got time for one more question, maybe two if they're quick ones. So I've got a question here for Sean. If someone's BP or blood pressure is high, is that something that needs to be investigated further with nephrology? This person's rheumatologist suggests that they see their GP for hypertensive treatment.
It depends. So it's a bit like the ingrowing toenail, broken leg, is it lupus question. So high blood pressure in the general population is very common. So it may be that this has just occurred as a separate finding. However, if there's lupus and it's affected the kidneys, because of this close relationship between the kidney and blood pressure control, then patients will often have higher blood pressure. And I think if I saw someone with high blood pressure, I would want to know their kidney function and their urine dipstick results, and would advise in the context of that. And then it might be appropriate for the GP to manage or for a nephrologist to be involved. Oh, actually, one other thing about that, sorry. And I don't think that's a case of kind of passing somebody on, because blood pressure is often very high when you come to hospital because of the excitement of a hospital appointment. And often if you repeat your blood pressure at home with your GP, it may be much, much better. So it is correct to go and have it checked at your doctors before starting treatment.
Brilliant, thank you ever so much.